Welcome to Talking Impact, your go-to podcast for exploring the powerful connection between mental health, education, and resilient youth. Join us as we uncover insights and stories that inspire classrooms, stronger minds, brighter futures, and a lasting impact in our society. Hey everybody, this week on Talking Impact, we have Dr. Robert Tanguay. You don't want to miss this episode. He's a psychiatrist, policymaker. He spent his career developing long-term recovery systems of care on a policy level, but also doing acute treatment for individuals through pain medicine, as well as long-term recovery-oriented processes. Today we're going to talk about his work in mental health and addictions, the opioid epidemic, as well as what we're doing as a society and what needs to be done, not just to help people recover from addiction and mental health, but how to prevent it, how to get upstream, and how to ensure that every family, every child, and every school has the supports that they need and the tools they need to help young people not just avoid risk, but to thrive despite the risk. Let's start at the beginning. Your story is super compelling, and why we've connected, I think, is we have a lot of shared experiences, but also shared mission and vision for how we can help improve the world, improve people's lives. But take me back to the beginning. Where did Rob's story start? What was your childhood like?
I'd say it's a good question. I grew up with a single mom, and my brother and I, my parents divorced when I was young. We moved from northern Alberta down to southern Alberta into a small town by Lethbridge, Coaldale, and my mom worked full time and went to school at night while we were growing up. So we learned real quick responsibilities. The slogan in the home was, you want to play, you got to pay. So there was no sick days. There was no sleeping in. You got up, you went to school. That was the reality, making lunches, doing chores, cooking meals at a young age to help out, knowing that, my mom was trying to do the best to support us. And she did. She gave us a fantastic life. We didn't have a lot of stuff that a lot of people have. And I think that partly is a driver for me, is growing up with less than some others, especially in a small town. You kind of know who has less than others in a small town.
I was going to ask, how did you know that you had less than growing up, and how did that affect how you thought about yourself or your future?
Yeah, I think that it was probably, kind of when you started recognizing clothes, right? So we went to the local sand store, or I don't even remember what the other one was, but I remember not wanting to go. And so friends were wearing, Air Jordans and Levi 501 jeans, right? Those were, and I had to wear Lee's and Payless shoes, high tops, which, is what it is. But, I know most of my friends didn't have that. You start to see that's, and so that was probably kind of junior high when you started to realize it, and then, but even at a young age, I would have been in grade 4 or 5 when we were tying clothes hangers with yarn and then going door to door and selling them to people. Me and a good friend of mine, Bob, who is quite a successful individual now and owns a very large painting company. When we were talking about this the other day, but we were doing that. We would go out in our bicycles with garbage bags and collect bottles. We would dig earthworms and sell them to the fishing shops. 25 cents a worm. We would do everything we could to put money in our pockets because we didn't really have a lot. And so, I think that was a driver for me for sure. So between having a tough mom who really stuck to her guns on roles and responsibilities, earning, what you get. So Saturday morning, you did your chores. If you didn't do your chores, A, you didn't get to leave. B, you didn't get your allowance. And well, what does every kid want to do Saturday morning? Get out of the house and go play with your friends. At that time, And so that was, these were just the realities of things. The being a responsible individual and getting your stuff done.
Yeah. Having a few brothers and a single mom, how did you start to, in the middle school period of your life, start to kind of form your own self-concept? And how did your mom and her, dedication, commitment, and how she modeled it, how did that affect, how you viewed yourself and how you viewed your role in this world?
Yeah, I think if I look at myself today, it's hard to think back to that time. I mean, I don't remember being jealous that other people had dads or stuff like that. I still idolized my father. I just rarely saw him, and I think the anger grew as I got older. Of like, why aren't you around? And when we are with you, why do you just work? And it didn't really make sense to me. But I think what it does is fuels you to try to be there for your own kids. I have 2 kids, and that's really important for me, is to be there for them. And I still, maybe not as good as I'd like to, but name a parent that feels they are as good as they'd like to. But I think that's probably the biggest driver, is family first, and that's a major piece for me. And especially just coming out of the summer and kids are back to school, but during the summers, it's always family first, kids first, holidays. I take all my holidays in the summer other than my Christmas holiday. Like, everything is about that. And trying to provide the best life to my kids, while at the same time remembering, what kind of helped me be successful and helped me, really push myself through university and prior to that in business was always about the responsibility and hard work and you want to play, you got to pay kind of mentality. And so I want to figure out how to instill that into my kids as well, which is really hard, actually.
Yeah, absolutely.
Yes.
Absolutely. And we'll get more on that for sure, because there's so much that youth are facing. And when you were growing up with your brothers, just me and my brother as well growing up, and we were really close and supported each other in fights and other stuff as well, in sports too. But what was that like for your brothers as well? Did they have a similar experience, or did they get affected by that in a different way?
Yeah, so it was just, I have one biological brother, and so we spent a lot of summers together alone, because we'd go up to my dad's and he would work and we would hang out at the house, sometimes walk to swimming lessons, and we learned to be pretty independent, but my mom was already instilling this pretty strongly into us as independence, and so I still have a good relationship with my brother to this day because of it. And I think, it definitely builds a strong bond and a strong relationship. And there's definitely differences between the two of us. There's no question. When in junior high, my mom remarried, but remarried like a guy that I had known for years, who was a small town. He was our hockey coach and baseball coach. And Ryan and Tyler, we went to school together. They became, my brothers in junior high school. We hung out all the time, and our parents dated, and our parents moved in together, but their house was still open. So that kind of became the party house. We had rules for that too, right? Like, the house better be spotless before you have a party, and whoever stays overnight has to clean up the next day. So we had rules around it, and we stuck to it. And it was interesting because I think my brother and I, as we got older, got more angry at our father. And they, on the other hand, their mother left, and I think that really affected them. And so they grew up with their dad without their mom. So anyways, really fascinating sociological experiment. But they're as much my brothers as anything. And as one of them has passed away from an overdose, a complication of addiction, and the other one still living down in Lethbridge. And
that's awesome. as you grew and you're a psychiatrist and policymaker and are probably one of the busiest people I know. We have this shared fascination and determination to improve the resilience of people in this world. And we talked earlier just a bit about how that resilience was something that was really trained and modeled for you early on, and you didn't really realize that that's what it was until a certain point. But tell us how your journey after high school through business and then starting to get through college and figuring out what you wanted to do with the rest of your life, how that developed resilience in you, and what were some of the pain points that led you to where you are now?
Yeah, so it's fascinating. The term resiliency, I've never really thought about it until well into my career as a psychiatrist. We don't get taught that in medical school. We don't get taught the term much in residency. I mean, 5 years of psychiatry, and I don't remember learning much about resilience at all. It wasn't until I was watching a presentation by another group that they talked about resiliency and kind of the past experiences versus current supports and how that balances and shifts the fulcrum of where you are in resiliency. And then you start really thinking back of like, holy cow, and more so thinking about your patients. I remember learning about adverse childhood experiences in undergraduate. And
tell us about those. Not a lot of people know about
Sure.
these and how significant they are and a lot of the societal issues we have.
Yeah, so these are childhood traumas. I really wish that's what they were called, but adverse childhood experiences are ACEs. I was, an internist in a healthcare conglomerate down in the U.S. that started figuring this out from individuals losing weight and then kind of not losing weight and why were some people succeeding, some not, and they really started narrowing it down to these childhood traumas. And so, I again, these studies kept going, and these studies led to understanding these childhood experiences that were adverse, these childhood traumas, which I think they should be called adverse childhood traumas, but these childhood traumas affected all aspects of health. They affected cardiac health, liver health, cancer, diabetes, mental illness, addiction, early pregnancy, early sexual behaviors, longevity of life as a whole. Yeah, fascinating that quite simply what we learned from these studies is that childhood traumas affect everything as to who you become.
Why is that?
Well, it affects your neurodevelopment. It affects your resiliency. So, your brain, your frontal lobes develop differently inside of trauma. That then affects your ability to plan and coordinate in front of you, which then affects your resiliency and the ability, again, resiliency isn't the blow up clown that just keeps getting up. I like to think as resiliency as the rodeo clown that can see it coming, can avoid it if it has to. If it does, knows how to take a hit, knows how to respond and absorb it, and importantly, can recover from it. And so, realizing that our frontal lobes are all about our problem solving and our executive functioning. And if they're developing at a different ability or rate than somebody who doesn't have trauma, then resiliency may be affected as well as your inability to see the hit coming in the first place, to avoid it, to adapt to it. I think childhood traumas, neurodevelopment, and resiliency are all interlinked hand in hand. Now, that doesn't mean that everyone with childhood traumas is not resilient. That's very important. It just means they're more susceptible to having less resilient outcomes to hits that may occur.
Fascinating. We're going to get back to this as well, but I want to go back to when you're in university and didn't want to be a doctor.
No.
But things happen in life.
Yeah.
And purpose happens when you're resilient and you get knocked around a bit. Tell us a little bit about that.
Sure. So, again, look, I wasn't by any means an honor student in high school or junior high. definitely had uncontrolled ADHD. I spent a lot of time in hallways. Yet I wasn't even the worst of that. I had other friends that spent more time in hallways than I did. It was really, going to college was just an expectation. Like, my mom had planned for this. You're going to college afterwards. And so I went to college. I lasted a year. I simply did not have the ability to study. I didn't know how to study. I was a C student who, never studied in high school. And suddenly I'm in university and I have no idea. And so, from there I ended up in sales and that's where hard work really, made a difference. And
selling coat hangers still?
No. I was selling initially vacuum cleaners and
Kirby?
No, Filter Queen. At that
sold
time,
Kirby.
there's a couple of big sales pitches for Kirby and Filter Queen, but yes, same idea. It was no different. And then kind of worked my way into owning companies and being a corporate representative, moving to New Zealand, expanding franchises. So several different pieces to it. And that was purely because I could outwork everyone.
Yeah.
Like I could work and work and work. And that was instilled by my mom. And my brother's the same way. He works and works and works. And so, going back to university was I was in New Zealand, and it was like, there's an unfinished piece of my life, and that was university, right? Yeah. And I was 19 and started in sales and was working 12-hour days, 5 days, 6 days a week sometimes, in a van, traveling different towns, right? And I worked and worked and worked, and I did that for almost a decade.
Was there something missing that you felt, or?
Oh yeah,
or
university, life, right? What happened to being the free, fun university student, even though, I did well financially as a young individual, and, we worked hard and played hard. Mm-hmm. And we would come back on Fridays from being on the road, whether I was working in Saskatchewan or Calgary or wherever. And, we would hit the pool hall and all hang out, big group of salespeople. But it was never that university life, that thriving for knowledge and education. And I would read, the Ogmandinos and the Zig Ziglars and all of these bettering yourself. Became a huge Tony Robbins fan and was just reading all of this and loved reading and knowledge, and was like, where was this guy when I was in college? And realized that learning is just hard work. You just got to jam it in there. And so really wanted to go back to school. So I was in New Zealand. I was a corporate vice president, and had just decided I want to go back to school. And I had no debt. Yeah. I didn't have anything tying me down. And so I quit my job, moved home at 29 with my mom and stepdad, and started university. And because I was a college dropout, I didn't just get to start university. I started in the summer taking one class at a time as a part-time student that I didn't have to apply. I just paid for a course. Went through 3 or 4 business courses, had a 4.0, applied then into business administration at Lethbridge College, which had the nickname of Last Chance College at the time. No offense to Lethbridge College now, because it's really where I got my start going. I shifted to general studies because I wanted to do more than just business admin. And I also found it hard. I had owned my own companies by then. I was involved in selling franchises. I was the guy that would go fix the franchises. And now, I've got a 30-year-old trying to teach me business who had never run their own business before. And I found it very odd. So I was just like, I got to go do something different.
Did you fall out of love with business, or you just knew that there was something bigger that you needed to find?
I just think that I wasn't interested in learning the university level of it.
Yeah.
It just wasn't and I took I wanted to upgrade to go to university as well. So I was taking some course. I took my Bio 30 and Chem 30. And I was like, this is kind of cool stuff. Like, again, that was not the high school student me at all. So I ended up switching into general studies, then applying to the University of Lethbridge for biochemistry, and then learned all about their neuroscience program and switched to neuroscience and got some grants and research stuff. And yeah, it was just happening, right? Like they say, life is what happens when you make other plans. I was just going with the university thing, and I was not sure what would happen. And you're in science, and everybody in science wants to go into medicine. Not everyone, but that's a big piece. I had no interest in being a doctor. And friends encouraged me to come to a lecture done by a lady named Adele, who was part of the admissions coordinator at U of C Medicine. And she's this most amazing lady who knows everyone by first name. I don't know how. She sees you and knows you. Just has that part of her brain that's incredible.
Great gift. I wish I had that.
Yeah, me too. I don't. And so she did this incredible presentation. I thought, man, that looks better than cutting rat brains. I think I'm going to apply to medicine.
Cool.
So I studied for my MCAT, took a course in Calgary while doing a research AFMER grant in Lethbridge, and applied the next year and got into Calgary and Edmonton, and it just kind of happened.
Yeah. Tell me about the personal experiences at that time that really helped to define where it was that you wanted to take this medical career. You had some loss, and addiction was a big piece of it.
Yeah, it wasn't, so that's when my brother really started to struggle. So I had moved home, and then I moved in with my brother. And Tyler was working in the oil patch, had just bought a nice home, had a nice basement bedroom for me to move into. I ended up moving in with my girlfriend at the time, although she kind of did live there and kind of didn't. That wasn't really acceptable by her family. And we ended up, I'll never forget, we're in bed and I hear this banging and like, what is going on, and run upstairs. And my brother's girlfriend had overdosed, and my wife was in nursing school. So she starts doing CPR, and I'm calling 911, and we're in a small town, so in comes the fire truck, which I know everyone. And it's just like, oh, this is the most embarrassing. Like, it was shocking. But anyways, we jumped in and drove to Lethbridge to the Emerge. And I remember the doctor coming out and chastising us for being drug users. And I'm like, I don't even know what's going on here. Like, it was just crazy. And I remember talking to him after, like, dude, like, this is crazy. This is a problem. And I'll never forget, like, him looking at me like, you're the one who's crazy. This is how everyone lives. And I was like, man, like, no, like, we're in our late 20s. Like, not everyone lives this way. This isn't the way it is. And then I ended up going to my parents and saying, I'm really worried. I think Tyler's sick, and I think he really needs help, and he's really struggling. And that unfortunately caused quite a rift between him and I. And but for me, and when it comes to university, again, I think that just comes down to the hard work and the desire to be the best at whatever I'm doing. And so that meant to keep going. And so I ended up in medicine. I thought I'd be a multitude of different types of doctors. You have no idea going in. And psychiatry kind of appealed to me because it kind of fit my research with brain and behavior and neuroscience. And then I did addiction rotation, was like, you see how it affects your family, and you see how it's affected. And, this was, Tyler had struggled for a while probably before, but things just got progressively worse for him. And I think that drove me into the field, even though, psychiatry. I thought about being a pain physician, and I thought addiction would help me be a better pain physician, but I enjoyed the addiction part very much, and being able to help people, and being a as much of a non-judgmental person as I could be, which I thought was cool about how addiction medicine is supposed to be that.
Going back to that doctor, you see it and hear it a lot, in homelessness and addiction and mental health my whole career. And there's that learned helplessness, maybe on a systemic level, maybe it's more on a person-to-person level, to say, what do you mean everybody's like this, Rob?
Right.
Did you start to realize that through your early work of how prevalent, maybe not everybody, but how prevalent and say contagious this disease of addiction is?
Yeah, I mean, this is the mid 2000s, right? So 2005, 2006, something like that. This is well before we started seeing fentanyl and opioids throughout. And it was, I think her overdose was actually, I think, GHB. I at that time it was kind of meth and cocaine and whatever other experimental stuff. There wasn't opioids around. Maybe a bit of like Percocets and stuff floating around, but so I don't know if it had touched me that much. It was a shocker to be kind of yelled at by the doc, and like just like being fully out of my element. Like I had no idea what was going on, right? Like I'm an undergraduate. At that time, it would have been my first year, so I was like still in Lethbridge College. Yeah, I think so. And Jen had just started nursing, so it would have been the same thing. And we were just shocked, right? But that experience hung on for me, and it's totally true. Physicians, if you're an emerge doc and you don't have a disposition, that's not good, right? And they need a place to send someone, and addiction was coming in and overdoses were coming in, and emerge docs didn't have that disposition. And there's almost that compassionate burnout, right? That compassion fatigue. Initially, I'm sure everybody was quite compassionate to someone coming in for an overdose, till it was like multiple every day, day in and day out. And then it's like where I've got nowhere to send them, nothing to do. And I think that really helped shape a lot of my career. Also, when I was 21, I was diagnosed with psoriatic arthritis. I went through multiple pain crises with inflammatory arthritis. Again, way out of my element, not knowing like what is going on. I was on prednisone for a long time and took Tylenol 1s as a pain kind of thing. And I remember running out of prednisone, and I was in sales. I was all over Western Canada, and I'd go into some local pharmacy, and like I ran out of prednisone. I really this is dangerous. And I would always get this feeling like I was drug seeking, like for prednisone of all things, right? And I would want to buy Tylenol 1s, and I need your health card, and I'm like, I just thought it was all ridiculous. Of course, a couple decades later, it's like, that all makes sense why they were doing all that stuff. But I felt the stigma on that side of what that was like, and then watched in my career as stigma grew and grew against our most vulnerable sector. And then watch the tides turn of treatment isn't working, and we shouldn't be doing treatment, and why are we funding treatment in the middle of a crisis and people dying? And I was just, what is going on here? None of it made sense to me. And again, the longer you get into it, the more you realize, well, maybe the way we were doing opioid treatment seemed to be more about profits and pharmacies and that so-called methadone ball and chain, and maybe we aren't very good. And I really I remember during my fellowship at the opioid clinic and giving people buprenorphine or Suboxone and giving them a week's supply at a time, and like everyone was in like, you can't do that, and they need to be dispensed and witnessed by the pharmacy. And I'm like, it's Suboxone, man. Like it's safer than Percocets and everything else. And I just finished my pain fellowship, so we were like handing out opioids and ketamine like candy. And then I go into the opioid clinic and they want to witness everyone under the tongue of this fairly safe medication compared to the other stuff that's out there. So,
what's that? What was wrong with the system? Like, I want to think about, how far-reaching this problem is. We all know somebody close to us who's either struggled with addiction or lost their life as a result of this crisis that you talk about. What's been broken about the system in helping them actually find recovery?
This is a really multifactorial question and answer. So we really have to go to the root. The root is simple. The Canada Health Act. The Canada Health Act in our universal healthcare system covers hospitals and doctors. So complex chronic illness like mental illness, addiction, chronic pain, not covered under the Canada Health Act. So first-line treatments for those are physiotherapy and psychology and addiction counseling. And so these are, the allied healthcare that aren't covered under our Health Act. And so quite simply, our most vulnerable who suffer with mental illness and addiction and a lot of chronic pain don't have access to treatment. So we have this massively underfunded system that, excellent if you have a stroke or you break your leg. Our acute care system was amazing. But if you have chronic complex illness, not so good. And that's really where the root of this really comes from. So you get that, you then have this miracle new drug called OxyContin that is non-addictive according to the company, and that cures pain. There was Purdue stuff on, there were CDs for people to start dancing again. Relief was spelt Percocet. It was this big sell job, and as physicians, I fully understand, right? Like, you have people who are suffering with pain and nothing that you can do for them. Can't send them to physio because it's not covered. Can't send them to psychology because it's not covered. Would love a psychiatrist to help, but they're going to say it's the pain that's the problem because they're not trained in it. Not much for multidisciplinary treatment, and if there is, it's a year or two to get into it. So, you have docs struggling in what to do, and all of a sudden the salesperson shows up and says, hey, we got a brand new medication, it's non-addictive, and it cures pain. Wow, what are you going to do? To everyone, right? And what's the initial response to most of these patients? Amazing. This was great. I feel wonderful. My pain is better, initially. And then you build tolerance, and then you see more and more prescribing. You have colleges where complaints can occur to physicians for not prescribing enough opioids. And suddenly oxycodone and OxyContin, Contin just meaning the long acting. So we used to only have opioids in like little 5 milligram tablets. All of a sudden you have 80 milligrams piled into one tablet. So, this is a whole handful of pills is in one pill. So people's tolerance on the street were going up. The number one drug on the street for opioids was not heroin, it was oxycodone. Then OxyContin was cut. Neo-Oxy came in. You can't snort it. You can't inject it. You can't do anything with this thing. You can't chew it. It turns to like cement crud in your mouth. So it lost all value on the street. In came illicit fentanyl. And by illicit, I mean it's non-pharmaceutical grade, partially processed in China, cut in Canada, and the United States, the two countries that don't have services for addiction, mental health, chronic pain. It doesn't fit in our universal system. Vulnerable people in the US don't have access to this. And so we see a fentanyl crisis start to occur in North America. And fentanyl started in Calgary, and I think the first death in North America in Canada was in Calgary from fentanyl. It hit BC and Alberta heavily, and they were green beans, shady 80s. So they were 80 milligram OxyContin tablets that were pill-pressed fake fentanyl. And so you've got this potent fentanyl that some dude in his basement is mixing in a mixer bowl, pouring it into a pill press with dyed green, so it looks like an OxyContin, with one pill having a massive dose of fentanyl and the next pill barely having any. That fentanyl pill causes an overdose. This fentanyl pill says that's not enough and I'm taking another one that causes an overdose. And we started seeing these overdoses crank up. Now, things have shifted so much since that time. There's no more shady 80s or green beans. People who are using fentanyl are looking for the most pure amount, and tolerances are increasingly higher. So there's where we sit today. And during this whole process, we haven't seen treatment ramped up.
Bring it back to those individuals that definitely need treatment, and the need for treatment is what we're about, and the need for prevention as well. But you think about the concept of resilience, and when you introduce, say, a resilient person to this severe, poison that's on the streets, that's being given out by doctors previously and easily accessible, where's that interaction between the person who is able to, or has the right supports for, or the right neurology for using it as needed and not getting sucked into the addiction vacuum?
Yeah, it's a good question. The data would suggest there's kind of two main drivers that shift use to addiction, right? And substance use is human nature. There's one civilization in all of human history that didn't use psychoactive substances. And they just happened to be on an island somewhere down by New Caledonia that had no psychoactive substances. So no way to utilize anything. No one was using anything. But we've used it in religious ceremonies and for getting better and doing better, from chewing coca leaves to drinking copious amounts of Starbucks. It's everywhere. And so what shifts the substance use into addiction is either those early childhood traumas and genetics, right? If you don't have the genetics to find euphoria from an opioid, probably not going to get addicted to opioids. But if you're struggling with some of those traumas, which often present themselves as anxiety and depression, and then you take this pill and it's all gone. No more anxiety, no more ruminating thoughts, no more fighting internally with myself, no more wondering, what is everybody looking at me and thinking about me? For the first time, and I have so many patients tell me this, the first time they feel normal. And what is resiliency, right? Early, that kind of negative experiences balanced by positive supports. So, you have more negative experiences, you're more likely to struggle with resilience, you're more likely to struggle with anxiety, depression. You take this pill or this substance, or your first line off the back of a toilet in a bar, or your first drink, whatever it may be, and bang, I feel normal. And then somehow as society, we want to judge that person, which is insane. That person, for the first time, feels good. And what are they going to do? Do what any person would do. Try to feel good all the time.
Absolutely.
And that's where addiction starts to occur. Somebody with chronic pain, they take the opioid, they get energy, they feel great, their pain is better, their anxiety's better, their depression's better, everything's better. To me, when I was initiating an opioid for somebody with chronic pain and they came back to me a week later and said, "Doc, this is amazing. That's a red flag. Like, medication shouldn't be amazing, right? This is something we got to monitor and we got to talk about and da-da-da. So, and now we have kind of opioid prescribing guidelines, and we shouldn't be prescribing to people with untreated mental illness and traumas. And we've realized that all of these things are here. And
Pandora's box open.
We still don't talk about it.
I know that we are now doing all these things, but did we open Pandora's box? And if so, how are we addressing it on a treatment level?
Yeah. So now we're shifting the intergenerational changes that we see. So, the great generation, there was no such thing as mental health. The boomers, still really not that much talked about mental health. There was, asylums and, that's about it. My generation, Gen X, we also didn't really like to talk about mental health or mental illness or any of that stuff. That didn't really fit in the picture. But the millennials shifted that. And you got to see the Let's Talk About by Bell and all these other companies getting involved and breaking down the stigma and da-da-da. That's great, but our system better be ready for it, because now you have Gen Z who's just saying, look, I have anxiety, fix it. Just like if I had a broken leg, fix it. What do you mean I can't get it fixed? Why can't I go anywhere? And so our system now has a generation who's destigmatized mental illness and now expects to be treated no different than any other area of our health, except a system that's been undervalued, underfunded, and ignored. Our lowest paid doctors are pediatricians, family doctors, and psychiatrists. Under appreciated until you need one, right? Of course. So now we need family docs, and everybody appreciates them now, but yet they're so poorly paid. Our psychiatrists, our pediatricians, and access points are extremely difficult. And same thing in the addiction world, right? So addiction was a moral failing. Yeah. So we work all this time and energy in educating people on the neurological aspect that addiction is a disease of the brain, that it's full of mental illness. It is a part of the diagnostic statistical manual by the American Psychiatric Association. It is mental illness. And then all of a sudden, so now we see some treatment start popping up. And then all of a sudden we see this shift to, no. This isn't that people have a right to use drugs. People have a right to live their life. People use drugs on the street all the time because they don't have a place to use drugs. Suddenly we've shifted, and all that work we've done on breaking the stigma of addiction not being a moral failing or a choice, but a disease, is now being interrupted again.
Let's go there. Safe supply. It's a pretty contested issue, but we see the ramifications, especially in BC. We see not just what's happening in the areas where they're having safe supply, but we see its ripple effect. Significant rises in youth under the age of 18 overdosing, primarily alone when it's happened, primarily have a pre-existing mental health concern. Of course. Talk more about how that has really undermined a lot of the work that was happening previously to really understand it as the disease that it is.
Well, I'm going to give you some opinions, because that's all this is. So the first safe supply clinic actually opened in Ontario, and by a really dedicated physician who, from what I can see, saw the failings of our methadone clinics. They were not low barrier. I know a colleague of mine whose brother was living up in northern Alberta, struggling with opioid addiction, gets onto methadone and was told they had to move to Edmonton to go to their pharmacy. Money. So, we have this horrific moral failing inside of some of our treatment providers that were for profit. Very little money in the public system for this. And so safe supply came in as this low barrier access point, which, really if you want to really look at it, addiction medicine should look in the mirror and say, hey, maybe we might have perpetuated this process. So the problem with safe supply, there's kind of two pieces. One, the molecule. So if I'm an individual, or maybe even better so, maybe I'm in a region out in Eastern Canada that doesn't have fentanyl. So using hydromorphone to treat either heroin or hydromorphone addiction is fantastic. Absolutely will work. Using hydromorphone to treat fentanyl addiction doesn't work. It is not potent enough to deal with the tolerance that is built by individuals using fentanyl. And so that can lead to, yes, I got my hydromorphone, I'm going to take my hydromorphone, oh my God, I'm sick an hour later, because it wasn't enough. So, what's somebody going to do? They're going to sell it to buy their fentanyl. Of course, why wouldn't they? Like, it's just simple human nature, right? They don't want to get sick. Why would they? Opioid sickness is horrific. As what was long said, you can't die from opioid withdrawal, but you'd want to. It's actually not true. You can't die. You can, but the risk is very low. And so there was this kind of opening, but pharmacologically out in BC and Alberta, where we were being hit hard by fentanyl, less so in Ontario at that time when they were first opening, it may have made sense to some areas. The other part, though, was the protocols and process. So giving someone a bottle of pills every day and then not really having rules about how those pills should be used, or not incorporating aspects of motivational interviewing and treatment and mental health treatment, and focusing on, we're going to use this to move you into recovery and building hope. Rather than just saying, this is your med and this is the best that you get. Now, I don't think that's necessarily true either. I've met some incredibly amazing safe supply physicians who truly are working hard to help those patients move into more treatment algorithms, maybe even straight into treatment and possibly into recovery after that. And then, of course, there's all the politics behind it. But, the big issue is we didn't protect from diversion. So we're giving individuals who are struggling with addiction a bunch of pills, and many of those pills ended up being diverted. And initially, what was even worse is that the proponents of safe supply refused to admit that there was diversion and argued that it wasn't happening, which all medications are diverted, right? Like, this isn't, we know the reason we got into the opioid crisis is because people who were prescribed opioids for pain were diverting them. Like, it diverts. That's just the reality. Then the argument is, well, there's way more pain prescribing than safe supply prescribing. Well, turns out that wasn't true either. The economics report that was commissioned by the Public Health Office of British Columbia showed 11 million tablets of hydromorph were prescribed in 1 year, increasing the medical, or the morphine equivalents of opioid prescribing in Canada by 30%. So one province doing safe supply increased everything by 30% in the country for the amount of opioids being prescribed. Massive. Well above what the pain people were prescribing.
To just say it's addictive is an understatement. To see how contagious, I guess, is maybe a better term, to see that it's not just addiction, it's that it's a contagion, that it gets diverted no matter what.
Correct.
One thing I think is important about the conversations that we have, your involvement with Impact Society, is around kind of stepping a bit back from this debate that seems like a false dichotomy between safe supply or regulated supply. And it's really only dealing with two things, really. It's the biological aspect and the public health aspect. But there's so much more to the individual as well as the collective when we are trying to address an epidemic of this proportion.
Yes.
At the conference at the Western Canadian Addictions Forum, which we were at earlier this year, I met a researcher from the University of Alberta focusing on resilience. And their research that they published was showing a significant number, more than 50%, the majority of people leaving addiction treatment having a chronically low resilience score. Can you kind of step back and go back into the mental health aspect of it all? Because I really think that that's where a lot of the solutions that you've been presenting through the RAM clinic and your additional work are really pointed at. Is we need to look at it from a bio, psycho, social, and dare I say spiritual perspective. But maybe break down for me how that resilience interacts with that individual who's trying to get off the opioid and trying to find that balance or rebalance between their supports and their adverse experiences.
So importantly, the majority of people suffering with addiction are not suffering with opioid addiction. They're suffering with alcohol and other substances.
So number one is alcohol, right?
Yes. So and now with Ontario, we'll probably see more with some of their new policies on alcohol. So we know alcohol is by far the number one culprit for addiction requiring treatment. But I mean, when we talk about resiliency, we talk again that I try to think of it as a scale. On one side, negative experiences. On the other side, supports and positive experiences. So we can build the positive with skills, with relationships, with peers. Everything that we do in treatment is on this side. But we can also reduce the negative experiences with trauma therapy. The 12 steps also goes into recognizing traumas in the past and kind of dealing with them. So we can start tipping the scale. And when we tip that scale, we shift the fulcrum to becoming more resilient. So resiliency can be done in treatment. And that's a big part of what we should be doing. So, those negative experiences, we can also start treating the mental illness piece. So treating the depression, treating the anxiety, treating the trauma, treating the ADHD, treating whatever mental health side that may perpetuate or exacerbate drug use or substance use, or gambling or sex or internet or whatever the addiction may be. Treating some of those underlying issues can reduce this, while supports, right, and skills. Addiction, we all have skills, right? We have their toolbox of skills,
nunchuck skills.
Whatever it may be, right? Some people's got tons, some people have a few. Addiction is basically replacing most of those skills with the substance. So when I feel bad, I use. And I've been fortunate enough to have the opportunity to share people's journeys and help treat and support them. I compare myself to a navigator in helping them navigate. And I hear it over and over again. I had a bad day, I used. Because that was what was ingrained. I learned that first day I felt normal. This substance works for me. I'm going to keep using it. And let's not forget, Freud gave all his patients cocaine because he believed it was the answer.
There's some dark history.
And it worked initially.
Yeah.
Initially.
But then?
Right? Then after time, a lot of these substances don't work. Alcohol, opioids, methamphetamine, cocaine. They initially are fantastic, and then they make the anxiety worse. And they make the depression worse. And they make the pain worse. So there's this kind of piece of, do I have anxiety, or is the alcohol causing the anxiety? Do I have depression, or are the opioids causing the depression? The chicken and the egg, and that's part of my job, is teasing that out. But, treating those underlying pieces and then giving the skills. What do I do when I feel this? What should I do? Because everything inside of me says, go use. So what can I do instead? And then when I do go use, we can't shame that individual. They have enough shame built in for, I did it. And they have the internal voice telling them how bad they are. And their mom's voice, or their sibling's voice, or their spouse's voice, or their kid's voice telling them how bad they are. Instead, it's, no kidding. This is what you've always done. let's walk through, and this is an opportunity to learn from what happened. This is part of treatment. And let's come back to figure out what we could have done instead. And let's make a recovery plan. And so resiliency can be taught. And grown.
How? So that I love that, because we know this. We know that when an individual is given a holistic approach, and there's different paths, and there's some where it's a taper down and you need to help them really long-term stabilize from their addiction issue. Others are more ready to rebound from day one. That said, it still requires that system of support, that relearning, that teaching, that skill development, as well as that interpersonal development to balance that scale.
Totally.
Takes a lot of time, takes a lot of money. How does that get scaled to the extent that we need it in our society, where it is actually valued, like our hospitals and our ER?
Well, two things. One, we got to look in the mirror and start putting, money where mouth is, right? Like, nobody's having debates on whether or not we should treat cancer. How is it possible we're having a debate whether or not we should treat addiction? Well, the reason is it's because it's those people on the street, them, they. I mean, quite simply, this is discrimination, this is stigma, this is often just frank racism. So we've just got to have some political will, and we have to decide we simply won't take the fact that when my loved one is ill, or when I'm ill from addiction, I should be able to get the help immediately. So that's a piece of it. The other piece is it's cheaper for someone to get into recovery than to keep them ill. So and that's true with most chronic illness. But so one part is building up the system of treatment. The concept is a recovery-oriented system of care. This is now being termed the Alberta model, but it's important to remember ROSC, or the Recovery-Oriented System of Care, was first developed by SAMHSA, which is an American group. They published that back in 2010. Later in around 2017 or 15 or something, the CCSA, which is the Canadian policy group, federal, endorsed ROSC and said all provinces should do it. And then Alberta was the first to move forward and say, we're going to do it. So ROSC means adding in access to treatment and recovery in every area of our society. School, hospital, jail, workplace, primary care. It's got to be everywhere. But in that, we've got to start talking about prevention and education. And this is where our schools are so important. I've often said, CBT should be taught in grade 1, 3, 5, 7, 9, and 12. And so when you graduate from high school, you're an expert on cognitive behavioral therapy.
How to do it, or how to
do it, how to use the skills, how to whatever. The hard part is trying to convince teachers to teach CBT. So then we've got to figure out a way to build resiliency in children, to make it easy for teachers and part of a normal curriculum, so that when something happens, they have the skills to deal with it. They're resilient. And this is literally what attracted me to Impact.
I love that.
Where we are.
And what attracted me to Impact was working in homelessness and addiction. And when fentanyl hit, hope was lost for so many. You used to get that second, third, fourth chance in addiction and have that long-term process that was available, although not widely available because of the medical system. But those that were in recovery knew that they could get back if they fell back. Right? But how do we take this recovery-oriented system of care, which implies this, I think it's a misunderstanding that implies that, we have to help people who are suffering from addiction recover from that addiction. But realistically, the work that we do, the work that we're doing at Impact Society is taking CBT, trauma therapy into life skills.
Yes.
And doing it preventatively.
Yes.
Prophylactically, if you will. Expand on where that is being done, how it's being done in different ways within the system of care.
Well, I mean, we're seeing things like mental health classrooms. We're seeing things like CASA here in Alberta. Foundry clinics throughout BC, which are providing mental health and addiction support to youth. Trying to be early intervention is important. But, what we really need to start doing is prevention. Like, early intervention is so important, and that's really limited and lacking. But prevention, how do we prevent people from going there in the first place? And that has been a struggle since This Is Your Brain on Drugs, Any Questions? Since that point, we have struggled with the concept of how to prevent addiction.
Teaching people about drugs doesn't stop them from using it.
According to the data, we're not sure it does. Now, at large population data, if we were teaching or not teaching, would there have been a difference? We don't know. Was society going here anyways? We don't know. But what we do know is we don't know how to prevent it. So there are fascinating experiences. A great one would be Iceland. Iceland had this horrific adolescent alcohol addiction problem. And so they looked at several ways of how we're going to do with it, but they did something fascinating. They focused on the family. They focused on sports. They focused on curfews. And by giving kids something to do, by bringing families together to do those things, and by eliminating late night kids walking the streets and they drastically shifted their problem. In fact, it's no longer a crisis. It's no longer an issue. But what were you doing? You were focusing on the family, focusing on resiliency within the family, focusing on building values. And, this was huge, giving kids something to do. So team is resiliency, right? Being on a team sport, being around other kids, learning to support each other, learning that what I do affects everyone else and what everyone else does affects me, winning and losing together, being okay to lose, feeling the pain of loss together as a team. These are huge wins, right?
Reminds me of Jean Coté from Queen's University. One of his terms that he likes to use is that good sport is the best way to build positive mental health.
Sure.
We just don't have enough good sport.
Again, supports is on the green side of the resiliency scale, right? It is the positive supports that we need.
And being in that team environment, learning to win, learning to lose,
Yes.
helps to develop what you talk about in resilience of being able to look ahead and prepare for either to change the situation or not just bear it, but to be able to get back up and learn from it and grow afterwards. Within the context of this recovery-oriented system of care, where do you see the ability for, whether it's the government on the government level as a policymaker or even on the policing side as a commissioner, how do you see that part of it, the medical aspect, the treatment aspect, how do you see them being a catalyst to get more prevention work done?
Yeah, so a recovery-oriented system of care includes police and first responders. It includes healthcare providers. It includes education. It includes politicians. It includes the community. It includes peers and recovery coaches. It includes everyone. But policing often end up with the brunt of society's failing. So, we as a society have created a humanitarian crisis in Canada of people living without homes, suffering with mental illness, suffering with addiction, and then even worse is the toxicity of the substances being used. So what a horrific group of issues. Nobody chooses addiction. Nobody chooses mental illness. Nobody chooses homelessness. They end up there, and it's a part of the illness.
Symptom.
And then we as a society choose to do nothing. That's the problem. So, policing, every time they intervene, there's a million iPhones around them recording them, and then you get a 2-second snippet, not the whole process of what occurred. And yet, without policing, we also see the effects of crime going up, community safety reducing, horrific things. Yesterday in the news, unfortunate story of a death, random attacks. And then of course meth and some of the drugs out there cause psychosis and can be devastating to our community. So it's all of it. It's everybody is involved, and policing is just one thing. But we can't just jail everyone, but we could look at helping people access the system. We look at Alberta, all of our provincial jails now have therapeutic living units in them. Right. So we're not incarcerating, we're rehabilitating. And from that, they get to transfer into the recovery community. So we're continuing recovery. From that, they can start working and maintaining and building an income and some capital while living for free and eating for free, and transitioning and reintegrating back into society. We have to look at the long path, right? And we get so sold on this one little piece. And then, of course, they become rhetoric and sound bites and political. We've heard the amount of saves lives is a rhetoric. So it was naloxone saves lives, and then Suboxone saves lives, and then safe consumption sites save lives. And it's just like, how many saving lives? Like, it's not about single entities. It's about a system that understands the pathway of that individual. So understanding the etiology and epidemiology of mental illness, of homelessness, of addiction. And so you need the experts there when you're doing the policies.
You mentioned earlier we don't know exactly what prevents addiction. What are some valuable traits or anything in the research or the work that you've done that is at least the best shot that we have?
So let me back up. Yeah. And we know some things that prevent addiction. One is access to a substance increases the use of that substance. Those who are vulnerable will end up with addiction. Hence, tobacco and alcohol being the two most prevalent addictions and the two most prevalent causes of loss of life. This is the biggest concern with some of the safe supply practice, is the diversion and increased access of opioids to everyone, especially with the moniker safe or safer. People believe they can take these and be okay. Marketing. It's safe. It's marketed. Horrific marketing. So proof is in the pudding. You don't see a barbiturate addiction anymore. I mean, every once in a while you see it. I have one patient and they get it on the internet and all this stuff. But it used to be something that was of concern. And then we realized benzos are safer. Now, of course, there's a lot of benzo addiction out there, but benzos were safer than barbiturates as a large global piece. So the more access to a substance, the less access to the substance, the less likely you will see people addicted to that substance. This is the argument in Ontario. We're going to make alcohol more available. Ontario has had, in all the provinces, the lowest amount of people struggling with alcohol because it was the hardest to get. Yeah. Now they've shifted to what everybody else in the country is doing and making it more accessible. So we're going to see more harms from alcohol. Cannabis. The belief was if we legalize cannabis, we'll take it out of the black market. Well, we haven't taken it out of the black market. And we've seen a massive increase in cannabis use, a massive increase in cannabis-related emergency department visits, psychosis to youth, early onset schizophrenia, which prognosis is much worse. So we've seen a lot of harms. I don't know anyone who can show me any benefits. Yeah. So, it's not always just simple as, if we legalize everything, will get better. Legalization is truly commercialization. Yeah. Decriminalization, I can get behind that, no problem. We can talk about it, but truly most drugs are decriminalized today anyways. Like, cops aren't shaking people down looking for drugs to arrest them. That does not happen.
Going back to the Nordic model, though.
Sure.
The Icelandic model, that prevention model, which we've seen the data not just in Iceland now, but they're doing it all over the world at this point. There's 97 countries, I think, that are implementing some form of the Planet Youth strategy. How does that help, like on a practical level, within that individual who's growing up in a community, maybe in a community like yours that you grew up in? How does that help lead to the prevention that we see in the data?
So again, when I said we don't know how to prevent it, I truly mean no matter what we do, we're going to see addiction, right? How do we reduce and prevent it for some people at individual levels? Well, we need to get back to primary prevention, preventing people from using substances in the first place, which many colleagues and friends will say everybody uses substances. Well, that's not actually true. I know a lot of people that have never used substances. And even in that, I know people who have only used alcohol and never used any other substance. They ended up still with addiction to alcohol. But, we have to figure out ways to reduce access to substances. We have to focus on reducing mental illness in children. That's a gaping hole that will lead to it. We have to focus on the community and the family. The community is so important. And family, I don't mean the traditional nuclear family. I mean, whatever your family may be, right? Everybody's family is different. But maybe your family is unfortunately not well and you're only with a few people. But if they're not well, we got to figure out how to make the family well. We got to figure out how to, and that comes to the community, right? What is that old saying? It takes a community to raise a baby or a child, right?
It takes a village.
Or it takes a village to raise a child. It takes the community, it takes the village to turn this around. We all have to shift how we're doing things. And right now things are going in a disastrous way. We just walk by people on the street, laying there. We don't know if they're alive. We don't know if they're dead. I see people walking by them all the time. Not too long ago, that wouldn't have happened. I mean, is that compassion fatigue? Is that desensitizing our community to it? I don't know, but it's not okay. It's really, really sad. And we really got to get back to the compassion for our fellow human being. And people don't deserve to live that way.
I love what we've talked about a lot is the concept of the family, and it needs to start at birth, baby and beyond.
Yes.
To support the parents, to support the educators, to ensure that those young people, whether they have those severe traumas in their life, it sounds like the opposite or the counterbalance to that is that community, that support, and helping them find the skills and the strength that they have despite those circumstances. And we study a lot of stories of resilient people, and that's usually the case. It's not just one person typically, it's a foundation of or a community of individuals that are able to surround that person so that they can continue to strive for better without being pulled back by what's missing. What does the world look like if we're able to implement a true recovery-oriented system of care from birth babies to treatment and recovery?
Oh, it looks better. It will lead to less deaths. We will reduce, community mortality. We'll reduce community morbidity, which means we'll reduce mortality and morbidity at the individual level. My neuroscience colleagues, people like Dr. Brian Kolb and Dr. Robin Gibb down in Lethbridge, their entire career is on early neurodevelopment, and all the way down. This is we're talking about well before there's even a fetus. Our epigenetics are passed down to our children. So it's such a huge piece that the development of that individual often it starts well before we're even born. So, imagine a world where every parent knows about what adverse childhood experiences are and how childhood trauma affects. What is it? What is childhood trauma? Some people may think childhood trauma is being in a car accident, but it's being emotionally abused, physically abused, sexually abused, being neglected emotionally and physically. Growing up with a mother, father who's struggling with mental illness, growing up with problematic drug and alcohol use in the home, things that we can try to prevent. Imagine if we put all of our resources into every person who's pregnant. And we're going to put all of our resources to make sure that child is born into a safe and healthy environment. Rather than waiting, right? I don't know how many people have said it. We don't have a healthcare system. We have a symptom system. We treat symptoms and disease. We don't prevent. We're not here trying to prevent. And I think this is where the focus has to be. We have to try to build resiliency in schools. We have to try to teach parents when they're early what to look out for, what's good, not how to parent. There's no such thing as a perfect parent, right? Good enough parenting. That's what I try to live by. Kids are going to get mad at you. Kids are going to fall. Kids are going to get hurt. Kids are going to be sad. Kids are going to have a bad day at school. This is just the reality of it.
We're not saying we're going to coddle them.
Right,
That's
exactly.
Yeah.
Yes. How can we improve parenting? And you said it, birth babies and beyond. We spend all this time with young new parents, educating them on the birth. And then you have the baby, and now what do I do? Yes, I took one class on swaddling a baby and one class on breastfeeding. But what do I do when they cry? What do I do this? What do I do that? How do I react? How do I respond? How do I take care of myself? How do I keep my resiliency high? How do I make sure I have the cognitive reserves to deal with this? What happens if I get mad and I yell and I snap? And what does yelling do to a child's neurodevelopment? And we don't talk about any of this stuff. And yet, the majority of new parents are taking birth and baby, just not the beyond.
Rob, it's been an awesome interview, and we're just about at time, but I have one more question. Knowing what we've just talked about, the importance of resilience, the power of our programs at Impact Society, how would you communicate to a parent or a teacher who's listening in terms of the value of this resilience building, this strengths building program is to help not just to prevent those things from happening, but to help them to thrive?
If I were a parent, which I am, I would be demanding it. I want my children to learn skills, and I can do my best to try to teach them. And my kids have heard the word mindfulness plenty of times in my home, and I don't know if they necessarily appreciate it all the time. But anyways. There are opportunities in our curriculums to teach this. And if it gives my child the chance to reduce their risk of having a mental illness and having an addiction and heavens forbid dying, then I want that. And I can't see how any parent wouldn't want it. And that's how I would say it.
What would you say to the educator in terms of how they can be the educator the kid needs to help them through that process of building those life skills, those social, emotional skills, and that resilience that's required?
It's got to be a part of a curriculum, right? I don't blame. Look, an educator is not a CBT therapist, right? I get that. I think it's educating the educator that skills can be taught, just like social studies, just like algorithms required for algebra and math. What do you do when this happens? Isn't that what math is? What do you do when you have this equation? Is it brackets first or multiplication first or exponents first? Following your algorithms to get the right answer. What do I do when I feel shitty? Following the algorithms to get there, right? What do I do when, I hear my mom worrying about paying the bills and I start worrying at night, following the algorithm of what to do. This isn't that hard to teach. And what we need and what Impact has done, which again is what attracted me there, is that it's a curriculum designed for teachers. You don't have to be a mental health therapist. You just have to teach simple skills.
Have to engage.
That's
what
it.
We see. And the teacher engages, the outcomes are even
that's
better.
It. And teachers want to engage. They're amazing.
Rob, we could go for another hour or
We
two.
could.
I think we'll have you back.
But I got to
Instead of
get
the
to
topic
hockey
do.
for my kids, so.
It's good to hear. Hey, we just wrapped up with Rob. What an amazing episode. Dr. Tanguay is not just an expert, but he is a compassionate individual who really is here to help individuals all the way to the system recover and provide recovery from diapers to diplomas, from birth and baby to the family system, through education, all the way through to recovery and long-term treatment. In this episode, we talk about a lot, but it all comes down to the clear piece that when we instill resilience in young people, when we help people recover in a real way, not just by giving them different drugs or different treatment plans, but actually helping them to build their internal strengths and their support system, we can take those severe traumas that can define people and turn them upside down so that they actually help to refine individuals to move forward and thrive. How clear it is if we actually look at it for what it is, as a disease, as a mental health, neurological, that addiction is the symptom, that homelessness is the symptom. However, as a society, we've ostracized, we've alienated, we've stigmatized, and at this point, we've actually abetted and supported that proliferation of addiction within our own society. On one side, we have people who are just turning the other, looking the other way, or just giving them what they want. On the other side, we have people who are, let's put them in jail, let's punish them, let's remind them how shameful their situation is. But when you look at it through that lens that he introduces, I don't see controversy, but I see a challenge. What if we actually treated diseases like diseases? What if we had a moon launch as a society to address mental health and addictions early and often, from prevention all the way to long-term recovery, instead of what we're currently doing? Maybe flip that on the other side. What if we treated people with cancer the same way we treat people suffering with addictions? I think on a societal level, it's a far more complicated and multi-generational, multi-sector process that needs to be put into place, and it's holistic, but it needs to be coordinated. But on an individual level, you're right. It is straightforward. It's not easy, but it's a consistency of not just love and support. It's not coddling and playing scared either. It's actually, as a parent or as a caregiver or as a mentor or as a coach, understanding that our opportunity here is not to win or lose, to do bad or good. It's actually to bring out the best despite the outcome, to help young people realize that what they're about, whether it's in a game or in a class or in life, is not about the outcome. It's about who they're becoming and about bringing out the best in them so that they develop those patterns that form our identity. But they're patterns, they're very clear patterns, like he talked about, algorithms of when bad things happen, what happens to me? Well, if you're a kid in an abusive home and you do something bad, you're gonna get beat. If you're a kid in a home without any support, you don't have anyone to go to when you have something wrong. So those patterns happen whether we are intentional about them or not. But when we're intentional about them and we focus on not the outcome or the symptom, but we go in and bring out the best in them despite what's happening, we start to build this scaffolded model of habits and tendencies and traits that actually build a defensive mechanism, a whole defensive framework called a strength-based identity that helps young people not just to avoid those risks and become susceptible to long-term addiction and mental health issues, but we help them learn to thrive. So it really is that simple in terms of focusing on what's great about our kids, not what's wrong with them. Not that we ignore what's wrong, but when something wrong or bad happens, that we come in with that approach. Not just to say I love you, but to show them how lovable they really are despite their circumstances. And on a societal level, that's similar to what we do with addiction. We focus on the symptom. We try to end homelessness. We try to squash addiction. And when that doesn't work, we're like, well, maybe we just make it safer. Instead of saying, these things are happening, how do we help every individual get back up on their feet to live a fulfilling life? I'd say, I've heard people make the analogy of what we're doing on our streets with the safe supply is akin to an open air hospice, that we're just giving them enough to help them feel okay versus actually helping them thrive and helping them recover in a real way. Again, I come back to that cancer analogy, which really is fitting. We're fighting cancer. We're helping people recover on an individual as well as systemic level. when it comes to addiction, we're just starting to get that that's the right approach.